but I'm going to ask them just very briefly if they would just introduce themselves and say where they're from, and maybe just one other point, something really that maybe relates to our theme for today. So I'm going to start, Anne. Can I start with you? You're very welcome.
Thanks very much, Sonja. Hi, everyone. My name is Anne Finucane. I'm a Senior Research Fellow in Clinical Psychology at the University of Edinburgh, and I've been the Marie Curie Research Lead at the Edinburgh Hospice for nearly 14 years now. And it's really great to be here today and to see just really the kind of passion and enthusiasm and warm welcome. So great to be here.
Thank you. Okay.
Thank you. I've spoken already this morning, so you know I'm Fiona Summers, part of Voices for Care, member of Voices for Care, which is part of the Institute. And I kind of said all I said this morning, introduced us. So yeah, and as I say, please approach us if for anything we can assist you with your research and work. Thank you.
Okay, thanks, Fiona.
Hi, I'm Audrey Roulston, Professor of Social Work and Palliative Care from Queen's University, and you've already heard me speak, and apparently I'm one of 2 professors of social work and palliative care in the world.
Okay, claim to fame. We're very, now, this is somebody we need to speak to.
My name is Daniel Caldwell. I grew up literally about a mile from here, so I'm from Dundonald. Originally moved to live in the west of Ireland. I'm the lead chaplain for the Atlantic Technological University, and we're just modelling a new form of chaplaincy there. And I'm also programme chair for palliative and end-of-life care for postgraduate studies in the university, which I got into completely by a chance conversation, as Barry mentioned earlier, when one of the academics in the university said, "Do you know anything about spiritual care? We need someone to write a module." And I wrote the module and ended up being programme chair a few years later, obviously. So I'm here under that disguise.
Okay, you're very welcome. Thank you.
And I'm Niall Galligan, and I'm one of a small but determined team of psychologists in Our Lady's Hospice who do exist. There's more than just me, but abandoned me today, unfortunately. So professionally, I'm a clinical psychologist. Personally, I'm a husband, dad, and recently a bereaved son as well, and recipient of, as a family member, of palliative care. So I think very recently I've seen palliative care from the other side, so to speak, and I suppose I've been very humbled and just realised how little I know in many ways as well.
Thank you for your honesty, and very sorry to hear your bereavement and your loss. So, I mean, I suppose one thing that struck me in terms of thinking of this theme today, and I just going to take a few minutes, was I am reflecting back in my career. I've probably been in terms of over 30 years, but as a student nurse, whenever we had to do an undergraduate dissertation, my topic I decided to select was the spiritual needs of older people in long-term care settings. That was over 30 years ago. And I think I just was particularly struck with Barry's point of it's from lived experience and from those aspects that we come and we bring ourselves in. And I had no intentions that would eventually be where I would be interested in going. It was just something that was my interest and an aspect that I could see as a student nurse that was missing. And everything you say, I absolutely, in terms of person-centred care, holistic care, if we're really thinking of serious health-related suffering, we need to have that holistic view. And I know I'm speaking to the converted in terms of in this room. But this is your chance to pose questions to the panel members. So I'm going to start with one, first of all, because I just was particularly intrigued by the analogy, and I'm going to direct my first question to Audrey. But I was particularly struck when she said about the shovels. Now, I'm not a gardener, okay? But I just thought, I like the word disrupt the soil, okay? So I liked that idea, and I thought, okay, so we are here a mixture of clinicians, researchers, policymakers, practitioners, broad it there. So if you could really say, in terms of thinking the social determinants, and we're thinking the social and the other aspects, what key priority would you say that we need to, whether it's for any of those groups of people, that we need to take forward and really think about collectively, and how would you what is the priority, and what key action do you think we need to take forward in terms of some of that really disrupting the soil?
Yeah, whenever you spoke to me earlier on, Sonia says, I must ask you more about that. I didn't realise I was going to be here.
I loved the analogy. I just thought soil shoveling.
Yeah, you told me you loved the analogy, but yeah, okay. So yes, in terms of that, you know, I love the analogy, I love the garden. I can see you've got nails, Sonia, which
that's why.
I don't have nails. So I think what we need to do is listen. You know, so it's about seeing the person. It's about seeing the individual in the socio-political culture that they are living in, with illness, without illness, their families, etc. And I think what we see, you know, if you've been watching the news over the last 6 months, you know, you'll see that the rates of racist attacks, for example, or the rates of homelessness, the rates of poverty, the fears about the removal of the winter fuel payment, etc. You know, those are all real issues that people with illness are all living with, you know, and the fact that they then have a disease burden on top of all of these issues, and they're maybe unable to work, they're maybe unable to go out, they have to have their heating on more often, etc. You know, those are all of the issues that we need to be thinking about. So when that person comes into your clinic, or when you go to see that person in their home, you know, it's really about trying to see what is life like for them, and actually then what can we do to try and alleviate some of that distress. Do we have networks? Do we know how to get in contact with people in the local food bank? Do we have you know, access to emergency payments for people for their electric, so that they can cook a meal, they can turn on the heating, etc. And the social workers who are on my postgrad diploma in palliative care, and the Northern Ireland Association of Social Workers in Hospice and Palliative Care here, are all telling me that when they're tasked to go into a family to tell the children mum is going to die, or to support mum to tell the children she's going to die, there's no heat, there's no food, there's no lighting. So how can you start to deal with some of those higher egotistical needs when actually we haven't got the basics? You know, or that person who has come over from Ukraine, whose husband is now dying, is being told you're going to be homeless when he dies. So where does she go with her family? You know, so I think when you uproot the soil and you get your spade out, that's what we need to do. We need to really start to understand these issues for these individuals and see what we can collectively and individually do to challenge the oppression that they're facing.
Okay. Any other, I suppose I'm thinking, does any of the other panel members want to come in and add to that? I really do want to get some questions. Or is there any questions or comments from the audience here? Want to follow on that, or anything different? I'll come back to you. Please think of your question. So, still keeping on that vein, and I'm going to look to yourself, Lucy, because then Fiona, one thing that came with me whenever you said, I think in your presentation, if they get the right person. So we're coming from the patient and the person perspective, and the carers, all of that, and it's if they get in the right person. So thinking of what we might do in terms of when the social work comes in and the professional side, from a patient and carer point of view, or bereaved carer, or a user perspective, is there anything we think we should take on board and really see what needs to happen to ensure? It felt a bit like if they get the right person, and it's like, is there anything more we can do to make sure they get the right person? Because we've all been users, we are users, we will be users of all of this, and I'm just curious of your thoughts on that.
Well, just following on from what Audrey said, really, and it's what came up in our focus, one size doesn't fit all. That really came up, and that's exactly what you've just spoken about there. And John mentioned it there when he said about the blueprint, the fingerprint. I thought that was a fantastic analogy. We do need, everyone is individual and their needs are individual. When you talk about getting the right person, a lot of the people on our focus group, some of them had nursing experience and nursing backgrounds and that. And so they were able to speak up, but some aren't. And we shouldn't be reliant on that, you know. So getting the right person is difficult. And that's certainly a challenge. In terms of the social care needs, and Audrey spoke about the excellent course that you have and the excellent students, Voices for Care members are involved in that course, which is a wonderful opportunity. Because when we actually did our focus group, one of our members spoke about an experience they'd had involving their social worker at the time, and it was a negative experience. And I was thrilled to be able to share with them that we are involved in training of social workers in the palliative care sector, and that, I mean, that class is exceptional. They're just so enthusiastic and so committed. But it was great to be able to give that feedback to people who are experiencing this on the ground, you know, and show them that the work is being done. So that was, and as going back to the topic, the students are north and south, you know.
Okay.
So it's a wonderful collaboration between everybody involved. And to be a part of that is great, you know, and to be able to say that to our members.
So it's really an example of where we have, I'm going to say PPI, but in that broadest sense, but involved in education of our
Yes,
future,
yeah.
but across the island of Ireland.
Yes.
So it's a good
And
example.
and going back to your question, it gives us more hope that we will get the right person.
Okay.
Yeah.
Okay. Yeah, that we can see some activities that are, yes, and I think we all have to believe in that. So Anne, I'm keen to sort of, I know we haven't heard your presentation, so I don't want to, you don't have to give too much away in terms of what's coming next, because I know you're going to speak to us after lunch. But from your point of view, because you're going to speak in terms of a particular intervention around mental well-being. But if you were, again, we've got some policymakers here, we've got researchers. What key point would you try, or key message do you think that's important that we need to hear? And then again, almost how would we start to do it? What's the key actions we maybe need to think of?
Yeah, and I think just following up there from just the previous chat, I think one important thing is, and a challenge as well, sometimes with psychological interventions, it can be quite individual focused, you know, and thinking about the needs of the individual. And sometimes we don't think sufficiently about the context or what that person has experienced. And so thinking about some of some taking more strengths-based approaches as well, and thinking about actually some of the resourcefulness and resilience that people have experienced given the context and what they have been able to do and manage is quite important and helpful. But in terms of mental health and well-being, I think it's really important to kind of just raise awareness of the importance of this at the end of life. And I think everybody is quite on the same page about that here today. But if you look at some of the national strategies outside of palliative care, like mental health and well-being and the discourse in general, there's rightly a real focus on like early intervention. There's a big focus on perinatal and neonatal care. That's extremely important. But actually what we miss, and in Scotland as well, on our mental health strategy, we see a life cycle approach. There's like really focus early on, but there's actually nothing has been said about mental health and well-being needs towards the end of life, and recognising this as a key and important phase for people that are faced with an advanced illness and for people who've been bereaved. So I'd like to probably just, you know, emphasise the importance of mental health and well-being at the end of life, you know, and that's recognised as part of the wider discourse on mental health and well-being. So.
Okay, some food for thought. Any questions? Yes, Kathy, go and start, and then one at the back.
Thanks very much. Kathy Payne from the European Association for Palliative Care. So unsurprisingly, I'm going to ask something about Europe, which is just, I'm wondering how much you feel that the work carried out today that we've heard so far is grounded in a kind of very centric in Ireland. How much of it is translatable to an entire European context? So I'm thinking in terms of Eastern Europe or low middle income countries. How much of what you have is shareable at a much broader European and maybe non-Christian sector of Europe?
Okay. Okay. You want to start? Okay,
Yeah,
thank you.
might as well.
Take the difficult question.
I thought it was the easy one. I think if we listen to people like Barry earlier and the feedback from the research that was done, and also John's approach to the provision of care in relation to the care centre, I actually think there's a lot about spiritual care that's actually transferable, not just within the Irish context, although I see the great value of it in discussions on the island, but actually in the broader European context. So I would be part of EPIC, which is the Nurses and Midwifery European Research Group, looking at spiritual care across Europe, not just within an Irish context. And actually a lot of the work that's been done here within the island context is actually very transferable, as long as we continue to have momentum moving away from a traditional understanding of chaplaincy and spiritual care that some might still hold to, which is very much based around religious care, to a more embracing approach to spiritual care. And I think the other thing that I would observe in that space, although I'm not a nurse, but I would make this observation, I think that needs to actually, on the island of Ireland, have a greater impetus around how we educate nurses and clinicians in the delivery of spiritual care, not for 6 hours at the end of a module in 4th year, or a little course that we send them on for a week before we thrust them into the clinical world, but rather a genuine approach to embed an understanding of spiritual care across undergraduate nursing curriculums. You'll all be aware Fiona Timmins did a bit of research and looked at textbooks in relation to undergraduate education, and made the observation that almost all of them said that nurses should be able to deliver spiritual care. None of them actually defined what spiritual care was or how it could be delivered. And I think there is a real niche there for us to respond to. But I think if we do respond well to that, and in a change in social and economic and cultural environment, I think there is an impetus on us to respond to that. I think all of the findings will be transferable irrespective of the economic situation of people in Eastern Europe. And I travel in and out of Eastern Europe as the chair of a charity based on the island of Ireland, and I think all of the findings would be transferable because they're principle driven, not driven around a particular religious approach. That would be my observation in my space.
Okay. Do you want to comment in terms of the psychological space? You thought you were getting off there.
Yeah, I guess, just listen to Daniel, I think it comes back to first principles. It's attuning to the person in front of you and developing a skill set to do that. And sometimes that is a skill set. The reality is sometimes it's more innate to some people, and sometimes for various reasons or various circumstantial factors, you know, it's not as innate to have the vocabulary or the antenna to pick up on what someone is feeling on a spiritual or emotional or psychological level. But it's a basic human principle, as is end-of-life care. And I think that's the thing that probably energizes this field, I find, so much, is it is universal. You know, death and dying and end-of-life and grieving and loss, it's a universal human experience. And I mentioned my own experience because there is no distinction between the personal and professional. Ultimately, you know, it's an experience that will come to everyone. So if ever there was an area that is universal in terms of how it translates across borders, it's end-of-life care, it's palliative care, you know. Yeah. Okay. My take on it.
Okay, thank you. I think I had a question, one at the back there, and then we'll take the other one. So one at the back. Do you want to say who you are, as well, and then pose your question?
Thanks. I'm not sure whether it's a question or a comment. I don't know what it is.
Okay.
I was very taken with the piece, how we die stays with those who are left behind. And my area is spirituality for years. So my husband died 4.5 years ago, and I now work with widowed people. But what really struck me, and I'm from Voices for Care, sorry. What really struck me listening to all of it was, I only realised this year that bereavement even was part of palliative care.
Okay.
And the number of people who really want help. I was very lucky to get it, but there's lots who don't. I'm part of a group where there's 150 people who are widowed, and they've all sorts of spiritual issues going on, psychological issues going on. And if we can intervene, we're now preparing them for a much better death. But also their families, their friends, any bit of healing we do, it ripples out all around. Obviously, if we can get to the dying person first, it's great. But it's around interdenominational, all faiths and none. I don't know whether that's... It's about bringing people together, I think.
Mm-hmm. Okay.
Whether it's caring for carers or giving nurses, you know, an afternoon, you can do an awful lot in an hour with people on a spiritual basis.
So if I pick up the question, if I try to phrase it as a question, I think it was interesting your point that you weren't aware before that bereavement care was part of palliative care. So if I take that, if we have any, because we have expertise here in terms of social work, we have psychologists, we have spiritual, and we have user experience. Anybody want to comment in relation to how we can ensure and make sure that that format, that education, that part of it is really recognised and developed? And I'm thinking from a research, clinician and policy perspective, and or.
Okay. I suppose as a social worker, working in palliative care, when I first started specialising in palliative care, I was told you deal with the person who is diagnosed. They are your service user and you support the family along the way. And as soon as the person in the bed died, we were told we had to close our involvement because we were no longer the social worker for that family. And that was quite a shock for me. So my first research project was looking at partners bereaved through cancer for my master's, and it was probably 20 plus years ago. And the interesting thing was my line manager was saying to me, well, if you think they have any needs as a bereaved person, you can see them in your lunch break. So it wasn't seen, so as a community social worker, it wasn't seen as part of my role to support the families into bereavement because they weren't known to us as a service user. And it was really hard to start to switch that. So when I moved then into specialist palliative care as a social worker in Marie Curie, I was delighted then that I could see that it was an integral part. And that was around the time that we had the NICE guidance come out and bereavement service leads were appointed across the hospices. And it was great to have that, but it was still seen as the unseen part of your job. You know, so the doctors and the nurses saw you on the ward working with the patients, but they didn't see all the work that went on behind the scenes with the families or whenever the bereavement support that was being offered. So I've always felt as if it's been the poor cousin. And the findings from my master's research were that if a relative died in Marie Curie or a specialist palliative care unit, they had all singing, all dancing bereavement support. If they died in the hospital, they got the bereavement booklet on the way. And if they died in the community, it was there's the number for crews in case you need any support on down the line. So we find there were a lot of disparities around that. And I think there still are challenges, like you have said there, in terms of people accessing support, people knowing where to go to and when. And we need to raise the profile, saying that bereavement is an integral part. And I've been involved in writing national guidance, you know, for bereavement in Australia, in Ireland, and we're looking at it here again for Northern Ireland. So we need to bring it up so that those people are supported throughout that journey.
Yeah, and I think it picks. Anne, do you want to come in? Yeah. No, sorry, I thought you raised your hand.
Yeah, just to add there as well, I just think it's thinking about training and modules on grief for nursing student nurses and for those that are training in medicine, because we know from David Clark's work he did a census of all those people in a hospital at a particular point in time, and 10% of people in a hospital died during that admission, and about like 25 to a third died within that year. But like we know that in hospitals many people will die in that stay, and if you think at particular departments like an ICU, that's even very significant. So any kind of health and social care professionals working in that setting need to recognise this and have some strategies and tools. Many of them will be very good at doing this, but others could do with some support. So I think it's that education and training within for nursing and medical staff.
Thank you.
I mean, I was quite moved when I heard the Voices for Care scenario and feedback, in the sense that people felt abandoned or felt left alone. And I think that's a real challenge to all of us in this space. I work closely with Mayo Hospice, which is co-located just across the road from the university. And one of the ways that they have stepped into that space is just having a walk and talk with staff and bereaved family members around the lake pathway that's next to the hospice. And I'm not saying it resolves everything. I think there are a number of things that we need to do in this space. I think innovations like that, where people, when they feel ready, can actually walk around the lake and have a chat with clinicians and others who are journeying through grief, can be hugely significant and not hugely resource intensive. Because I think sometimes that's the argument that's often made, oh, well, you want to do that because you teach a module in bereavement and loss and we don't have the money to pay for that. But like, an hour walking around, sharing stories, building narratives, walking in quietness. I mean, I still meet one of the people who lost their wife to cancer 3 years ago once a month for dinner. And don't get paid for it. It's not part of my job description, but I think it's the human thing to do. And we have journeyed together over that time and built a relationship. So now it's not like, oh, I'm helping someone. It's actually we're hanging out. And you know, that's, for me, I think part of the space that sometimes I think pastoral care and chaplaincy fit into in this conversation that's often potentially overlooked. And I want to kind of predicate that on the basis that, having heard what I heard today, I think there's loads more that we still need to do in this space, but I certainly think that there are projects that could be highlighted that may be able to be rolled out very cost effectively across other places without having managers go apoplectic cost base.
Okay.
And be simple and be clear
Yeah.
in those spaces.
So in some ways we have the policy and we have the guidelines that's there, but then it's actually the enacting of it. But it's the person-to-person type piece that still needs to feed in and be part. Okay, I think we had a question here at the front and then one more. Okay. Yeah, go ahead. Sorry. Yeah. And just say who you are, please, too.
Thank you. My name is Kerry McIlfatrick and I'm the CEO at Laura Lynn Children's Hospice. And we have a fantastic interdisciplinary team. We have a psychologist, we have music and play therapists, I have a bereavement coordinator, all of whom I feel have clarity around their roles in providing more so the psychological supports at level 3, level 4, but probably are less focused on the spiritual element of support. So it's something that we recognise as something that we need to do more of for our children and families. And so I'm wondering, if you were in my shoes and you were to focus your energies and, albeit limited funding, at investing in building spiritual supports for our families, where would you focus your attentions? Would it be investing in recruiting a chaplain or a pastoral care worker, or should I focus my attentions on training and upskilling? And I was taken by Barry's comment around, you know, the risk of over-specialising things, and, you know, should I be investing in upskilling my health and social care workers in delivering more localised spiritual care and investing in others? Where would you focus your attentions? And that's to the panel in general.
Okay.
Sorry,
That's a good question.
Yeah, it's a brilliant question, and it's great that you're here today. And my advice would be to upskill on everybody, because I think, as we've heard, you know, if you look at the spiritual care competencies, everybody should have a basic level, you know, and that's then about how they meet that need and how they know when to escalate. But I think it's, you know, having worked in Marie Curie, the nurses often came to us and said, when I was bathing this person, or we were doing their personal care, or at 2 o'clock in the morning, this is when they came to me. So if you invest in another chaplain, they're not going to be there 24 hours a day. So I think what you have to do is upskill everybody else so that they feel that it's sort of an integral part of their role and they feel equipped and competent to deal with it.
And I would just make the observation, I don't think the choice should ever be either or. It should be both and, as far as possible. And I understand budgets are always a constraint, so I don't live in a cloud somewhere that just doesn't recognise that. But the reality of it is, I think there is a generalist approach to spiritual care that's often described in these contexts, where we talk about people across interdisciplinary teams having skill sets and capacities to show compassion, to listen effectively, to be attuned to people's spiritual needs. However, in my experience, there is also a more specialist context, and I think to have both, whatever model of funding you need to use to get to that point, would actually produce better outcomes for the people that you're trying to serve, in the sense that there will be times where your staff will need to refer to someone who has more training, more expertise, more knowledge. It's not that they can't deliver a generalist approach, but I think there are specialist complex things, like I'm working through with a family the issue around forgiveness, and actually, to be honest with you, it's taken me longer than I thought it would, because it's a complex space, and I don't know that it would be the appropriate space for a nurse to step into, not being derogatory to nurses at all, but actually the knowledge base that you approach that with as a specialist chaplain or have specialist knowledge in chaplaincy is actually forming part of the process that we're making a journey on. So I would actually encourage, as far as possible, to go a both and, not an either or. But obviously upskilling all of our staff around spiritual care, I think, is essential, because I think undergraduate education has probably airbrushed that out of the care paradigm, and yet we keep having statements about holistic care. Well, if it isn't physical, psychological, social, and spiritual, I'm not sure it's quite holistic on any measure.
Okay.
I might just pick up on Diane's point as well, because I think, and picking up on Barry's point earlier, I think it's almost like a dual approach. You know, we definitely need to make psychological care, spiritual care, social care everyone's business. However, in real terms, whose job is it when they're brushing their teeth in the morning to think about these things? Whose job is it to listen to the podcast, to read the literature, to go to the conferences? Everyone can't be that person in all domains. And I think I mentioned at the outset, being humbled by the personal experience of palliative care, but also realising I've moved into this field about 3-4 years ago, and how much scope there is to learn just psychological literature and evidence-based just in this one area. So, we do need people whose job it is, whose salary pays them, and their passions lead them to actually develop expertise in an area. We can't be experts in every area, but share those skills, cascade those skills simultaneously. I think that would be my philosophy on these things.
Okay, and I'm just going to make one comment in terms of, because it's a research symposium, is also the evidence base around
Absolutely.
all of that.
To be on top of
Yes,
evidence base.
yes.
We can't be on top of every evidence base in every field.
Yeah. So I have one more question, and yes, if you go ahead. And then what I will say is this has been great in terms of our discussion. I'm conscious that we're between you and lunch, which is the other piece, so we'll have the last question. But if there's anything you want to ask and comment, I'm sure our panel members will be more than happy to grab them over lunchtime and keep on the conversations going. But go ahead, please. Next question.
My name's Christine Campbell. I'm actually in palliative care, terminal diagnosis. And I just wanted to, not to any of the people in general, but not to anybody specific, but just in general, the use of digitised healthcare with the rollout of Encompass, etc., across Northern Ireland, across the trusts at the moment, and the big rise in the use of AI. And I'm thinking, do you feel that it's going to give service users an improved choice and quicker access to your services? And do you see it being implemented within your workplace to enhance patient experience or service user experience?
Okay. You want to start?
I'll tentatively attempt to answer that. We, Voices for Care members, were involved in a project being run down in UCD in relation to the use of AI in palliative care, and they were developing an app, or are developing an app. And it was very interesting how it developed over the meetings and things like that. And they were very receptive to our contribution, considering our contribution was quite negative, because we didn't actually agree with what they had done. We were really giving the person-centred approach, and they were coming at it from a different perspective, which is why the lived experience is so important. So it's still in development, so I don't have like a full answer to your question, but I just wanted to share with you that they are taking on board the lived experience, the carers and the families themselves, the patients themselves, because some of the discussions were around, well, who's going to input the data? What if they're not able to input the data that particular day, due to the pain thresholds or whatever it might be. So there was really useful discussions. I just wanted to share with you what's happening in the background. Yeah, I don't know if that's helpful or not.
Okay. So thank you. And in terms of an access to your services, so I suppose the question was all the developments around digital, particularly in Northern Ireland. We have our digital healthcare Encompass for those of you from the south of Ireland. So maybe Audrey, do you want it? Because I know you mentioned it in your presentation in terms of Encompass.
Regret that now.
But if people coming and wanting to access, will that help, hinder, enhance?
I'm
Yeah.
not suggesting that now it's going to be replaced by a chatbot.
Yeah.
Anyway.
Yeah.
No harm.
Yeah, I think there is a fear that some people wish they were being replaced by a chatbot. But yes, I suppose really in terms of a compass, it's now been rolled out across the 3rd trust now, which is Northern, which I see John nodding his head wisely as the first week of Encompass in Northern Trust. So lots of challenges with it in terms of the transfer of data, and then in terms of, it means now as a person who lives in Northern Trust, I can go online and I can see what's happening. But in terms of how it will help me access services, I think it's about information. It should help expedite the role of professionals at the ease of access. So a nurse driving around a community goes, oh, Maud lives in number 9. I wonder, does she need seen? Or what's happening with Maud, because I'm in the area. So she's able to look at it on her phone and access that information more readily and go into the person's house. Maud's my mother, by the way, who's 92, and the doorbell rang and the district nurse came in because she'd checked and she knew Mum was due for a call. So it expedites that in terms of, and she says it's great for her as a healthcare professional out in the community, and she can keep on top of her notes. I know that that's not the case for others. I know that some people, when I was in hospital myself as a patient, all I could see was the computer coming on wheels and the nurse was behind it, to say, you're due your meds now, and who are you? So and it was a challenge for them in terms of that, but they told me it resulted in fewer errors with drugs and the administration of drugs. So lots of positives in terms of that. But as for will it help you access services more readily, I don't know the answer to that. And I think, again, it's about people need to know that the services are available so that they can ask for them as well. But it should help in terms of you being able to see your blood test results or what's happening next.
Okay. So I think we'll pick that one up, but I think it should help. But I think the key message I'm getting is being able to know in terms of access what's there, and it comes back to the question, if you know the right person and if you get the right person to access that information, and all these tools and things are ways to enhance it potentially, but ultimately it's how they're used and implemented as well is an important factor. Can we just show our appreciation to all our panel members, please?